Welcome back to the podcast. Appreciate your joining us again. We are here with Will Morris, DPT. Will is a physical therapist with the United States Army, and he is currently stationed in California. He escaped the Hawaiian Islands recently and was returned to the mainland, and now is in a position where he can get in his car and drive 200 miles in any direction that he wants to. And I know that Will is from the lower 48. He appreciates that opportunity more than those of you islanders will ever understand. So, Will, thanks for being with us.
Thanks for having me.
Let's talk about pain. You know,
This is my favorite
I know
subject.
it is, and it certainly as hell is my favorite subject. My back has been hurting for about 3 weeks now, and I'm getting real tired of it. But I have a history of back pain. My back is hurt off and on for, 40 years. And I think probably that, most people have had a similar back pain history, us being upright bipedal humans. I just wrote an article about that. It appeared in PJ Media. Back pain is an interesting topic. I think it probably is the most common human pain complaint. People all over the world have back pain. Humans have back pain. Everybody that's over the age of 30 has some type of degenerative vertebral process going on that's probably identifiable on an MRI study. And back pain, as a result, is kind of an interesting thing because back pain and pain in general, but especially back pain, may or may not be the result of what you see on the MRI study. This presents an interesting situation within the doctor's office. You go to the doctor's office with back pain, he orders an MRI study. If you're older than 30, something's going to be wrong with your back. But the thing that is wrong with your back may or may not be the thing that's causing the pain. So we have to approach the resolution of back pain very carefully. As I said, my back's been hurting for about 3 weeks. And hell, I don't know. I've just trained through it. It's been bothering me a little bit, more than it normally does. I'm training through it. I'm handling the same numbers that I would have handled had I not been having the back pain. Tonight I'm going to deadlift heavy, so it's not going to be any fun, but I'm not crippled. I don't have any numbness, tingling, any neurological symptoms. I just have back pain. I know, Will, you see a lot of this in your practice because dealing with people in the Army, you're dealing with people that are over 30. You're dealing with people with back pain. What do you do?
Well, I think probably the most important thing to bring out with this is probably 10% of the people that I have come into my office have an acute injury, that they have an ankle sprain, they have a torn ACL, they have something that there was some kind of catastrophic failure of tissue, and that's why they're in my office. Probably 80 to 90% of those that I see are people that have some type of chronic pain or some type of undiagnosable joint pain. And then a large portion of those are people that come in with back pain. And so most of the patients that I see, whether they be military members or dependents, are people that come in with just pain. And that's their primary diagnosis. They come in, they have pain, and really whenever you look at their physical exam and stuff like that, like that's really what you come out with, that they don't have any catastrophic disruption of tissue. They don't have any diagnosable injury. They just have mechanical pain. And so the thing that you have to understand about pain is that pain is completely derived from the central nervous system. It has no bearing on what's actually going on. Like people can have horrific wounds and feel no pain. Some people can have very minor injuries and have crippling pain. You know, you see this all the time. People have a hangnail and not want to do anything with their hand, but yet we have people in combat, they get shot 3 or 4 times and continue on, don't even know that they've been shot. We know that the central nervous system is very important for the perception of pain, because surgery depends on kind of knocking out the central nervous system, and surgery, people feel no pain, even though there are barbaric things being done to the human body while they're under anesthesia for surgery. And so whenever you start to look at pain as not just necessarily that pathoanatomical approach that I have rotator cuff tendonitis, or I have a herniated disc, or I have degenerative disc disease, if you just look at it from the perspective that pain is the primary impairment, and then you address it with some type of biomechanical training, which in large part for me, that's teaching people how to squat and deadlift. And then you let people know that whenever you have mechanical pain, that for the most part, it's generally safe to continue to train through it. And most people will find that, especially with back pain, the back pain usually hangs around for 3 to 6 weeks, and then it goes away. And that's what we know of. That's what we generally call non-specific mechanical low back pain, is that we know it comes in episodes, and that what happens and what tends to make the episodes more frequent or make them kind of longer in duration is that whenever people have back pain, they get scared to do anything. So they take 3 to 6 weeks off. And then whenever you do nothing with your back, then you tend to become overly sensitive to continued pain. And so that's when you see people that have nothing diagnosably wrong with their back outside of the norm. And you see these people that will be in kind of disabling level pain for 16, 20, 24 weeks at a time, because it's very hard to force these people to do anything.
Well, and that's kind of pain is, after all, a mechanism that has evolved over hundreds of millions of years, and all animals at some level feel some kind of sensory input that we would interpret as pain. I mean, pain is how sub-rational beings learn things. It's how dogs and cats learn not to get slammed in the door. And, it's a finely developed mechanism. It's stood us in good stead for hundreds of millions of years. And, if you burn your hand, it hurts. You associate the burn on your hand with the thing that causes pain. So it's not entirely irrational to associate back pain with a use of the back, and to associate the pain with the idea that maybe we're not supposed to use our backs until the pain resolves. And it's difficult to communicate the idea to people that we know your back hurts, but you can deadlift. Not only will it be better if you deadlift, it won't hurt anymore if you deadlift. And it'll make the pain eventually go away, and eventually, over the long time, make the pain better. But that's counterintuitive, isn't it?
It is. And just like you said, I mean, pain in and of itself is an emotion. It has a very strong emotional component.
Well, there are emotional reactions associated with it because of the animal's history with pain. Let's say, for instance, a person who's been beaten every day for most of their lives is going to have a different reaction to the pain on the skin than someone who may associate occasional bouts of pain with extreme pleasure. This happens, boys and girls. So different levels of psychological association with pain produce different reactions to the pain. But if you burn your hand hurts. It hurts because of the burn. If you touch something with the burned part of your hand, you learn very quickly not to do that because it makes the pain worse. That's not the way the back works. But you can see why it would be why a person would be reluctant to go ahead and push through the pain. It's something that you have to learn how to do. It's something that you have to if like somebody comes in here with 3 years worth of chronic back pain, they can't deadlift. an empty bar, they never have deadlift an empty bar, they're going to have to trust me when I tell them that they'll be able to do 95 pounds a day. It won't hurt, and it'll feel better tomorrow. It will be counterintuitive to them. They're going to have to trust me. And you run into this all the time too.
Yeah, I do. And probably the most important thing that I do with patients that come in here that present with some type of fear with doing some type of movement that I'm asking them to do is demonstrate to them why the way that I'm teaching them how to do it is safe. Because like I said, I mean, pain has a very strong emotional component. It's tied directly into our limbic system. So there's a lot of instinct that goes into pain. And so people are naturally kind of hardwired to want to stay away from pain. But you can override that by instructing people, hey, I'm going to have you deadlift. This is what I'm going to have you do with your back. And this is why it's going to be safe. And I've been very fortunate to be able to have people come in and have the opportunity to show them, hey, I'm going to have you lift something, but I'm going to, one, show you why what you're doing now is wrong. And then I'm going to show you a better way. And I'm going to explain to you during that process why it's okay for you to do this. And generally, I mean, kind of my standard prescription for somebody with back pain is have them demonstrate to me how they've always been taught to lift something off the ground. And I'm very careful not to use the word deadlift, because if I use the word deadlift, that ties into people's fears that they have been told repeatedly or they've heard that deadlifting is bad for your back. But if I pose it to the patient like, hey, if you have to lift something off the ground, how would you do it? Like, what have you always been told? And virtually everybody will say, well, I'm going to lift it with my legs. And so then I say, okay, that sounds good. Let's go out to the gym floor and I'm going to have you demonstrate to me. I pull a mirror up beside them, have them lift something off the floor. And then I start showing them why their back hurts whenever they do that. And then I show them a better way. And whether they know it or not, I'm teaching them how to deadlift. And I teach them how to deadlift, how to get in the proper position, and then show them how to lift something off the floor in the model that we use as the deadlift. And they do that and they say, yeah, that doesn't hurt whenever I do that. And I'm saying, exactly, that's exactly how you're supposed to lift something. This is the safe way to do it. And then I start progressively loading them. And whenever patients will let me do that with them, I probably have just as much success, if not more success, than any of the other therapists that I've worked with, because that's the model. I get them squatting and deadlifting, and I explain to them a rational explanation why this is actually safe for you. And if their frontal lobe will kind of override their limbic system, and they will use cognitive reasoning to override fear and instinct, then they do just fine. But I mean, I would be lying to you if I told you that everybody could do that, because I have a lot of people that come in that there's nothing on God's green earth that will get them to ever lift weights again, because it's so deeply ingrained in their brain that they will never be able to do that again, that there's just nothing that I'm going to be able to do that. But for everybody that's willing and everybody that's able, squatting and deadlifting is the best thing that I can do for somebody's back.
Well, and why have they carried this baggage into your office? Who's told them this?
Well,
just out of curiosity.
For the most part, I mean, I don't want to like bash on other healthcare professions, but it tends to be that, especially your like primary care based physicians tend to be very risk adverse, and it's from a litigation standpoint, it makes more sense to tell somebody if something hurts, don't do it. Because if I tell you to deadlift and you come back and your back hurts more, you're going to blame the deadlifting for it. You're not going to blame the fact that it's a natural progression of back pain, that it usually escalates a little bit and then it starts to go away. Whenever you've had any increase in symptoms, you're going to say, well, it's because that guy told me that I needed a deadlift and I hurt my back doing it. And so you probably see more and more that well-meaning doctors and other healthcare providers are telling patients, well, you shouldn't do that because it hurts, when in reality, you show somebody the right way to do it, and you can, and no different than what you do or any starting strength coach does. Whenever they have a new trainee come in, you teach them how to do the lift, right? And you identify faults that they have. Do the same thing in my office. And, I have a decent amount of success being able to do that, but there's just some people that come in, and if that if somebody with the initials MD or DO after their name has ever told them that you can't do that again, there's really nothing that I'm going to be able to do, save working with them for a long period of time and being able to demonstrate to them that not only can they do it, that they should do it. And I have some success with that, but by and large, if a doctor's ever told somebody you can't do it or you shouldn't do it, they're probably not going to. And that's for the general population. That's totally different from people that have come in that were amputees or polytraumas or something like that. They tend to have a totally different mindset. They've been told, for the most part, that they can't do anything, and their biggest goal in life is to get back to doing something. And so they'll do whatever you want them to. But the general population tends to shy away from that, especially if a doctor's told them not to do that.
Well, I wonder how many people have been actually crippled long term by having their GP tell them, don't lift more than 25 pounds. That's
in the
just
short
so,
term, probably.
It's just so, I don't understand. What do you mean by 25 pounds? Does that mean you don't go to Walmart? You don't buy anything at the store? You don't carry the groceries out to the car and put them in the car? You don't pick your kid up? You don't essentially you don't interact with the physical environment anymore. You don't lift more than 25 pounds.
And that weight is totally
it's
arbitrary.
just a number that the guy jerked out of his ass, and it's just bizarre to me that this is still being taught to patients. And as you say, this is cover your ass medicine. Don't lift more than 25 pounds because
in the short term,
26 pounds. See?
Yeah, that's where things are going to go weird, is whenever you lift that extra pound. But in the short term, I mean, it makes sense on their end that if it hurts, don't do it. That will keep you from coming back into my office. I'm already overworked as it is. I don't have the time to give you a 40-minute evaluation to ensure that there's really nothing going on.
Well, and you don't have the background to perform such an evaluation anyway, because you haven't been taught anything about biomechanics, about skeletal loading, about spinal loading in particular. All you've been taught is pain. You've been taught about pain. You've been taught about the medications to prescribe for analgesia. You've been taught about how to get this pain patient out of your office as fast as possible. And
you're going to go by the clinical practice guidelines.
Well, of course you are,
because somebody comes in with acute back pain, or a back pain that doesn't seem to be a radiculopathy or some type of nervous involvement, that you're going to give them 6 weeks of non-steroidals. If it hasn't gone away at six weeks to about 18 weeks, then you're going to order a lumbar spine panel. You're going to send them to physical therapy, and that's just kind of general medicine. That's standard of care.
And because that's a standard of care, if you follow it, you can't get sued. Even though what you have done is not effective, you can't be sued. And it's unfortunate, and I sincerely mean this, it's unfortunate that that's how medicine must be practiced.
In my position now, I approve all the consults for the physical therapy clinic. Like me as the chief or the director of the clinic, I approve all the consults. And I would say probably 50 to 60% of the consults that come in for back pain are for people that have already, what they say, failed conservative treatment with NSAIDs and muscle relaxers and rest. And I can't think of anybody that I've had come in that was given that as their standard prescription and had them actually get better to where it didn't escalate to going to physical therapy. And once they come to my office, then now they're either going to be along the natural history or natural progression of back pain, where their pain is starting to go back down whenever they come, or they're going to have had back pain long enough to where now it's become chronic in nature. And then that leaves me with an entirely different patient like profile to have to work with. And I'd say that in the short term, it makes sense. At least intuitively, it makes sense. Whenever you're trying to protect your own medical license and stuff like that, it makes sense to say, well, if it hurts, don't do it. That seems like it makes sense. And in the short term, there's probably very little risk to it. But whenever you're a patient and your entire adult life has been told, don't do something because things hurt, and anytime something hurts, well, don't do anything, then you start to look, kind of the chronic effects of a whole bunch of periods of time throughout your life where you haven't been able to do something. And then that's how you start to see, people that I see in the hospital that are deconditioned at 50, 60 years old. They can barely get out of bed. They're walking with a walker. And I mean, I look at some of these patients and I'm like, man, that's 10 years from now, whenever I'm going to be the same age. And really the only difference between me and them is that I train on a regular basis.
This is probably a good time to stipulate to a point here. We are talking about, when we talk about back pain, Will and I are specifically talking about the kind of back pain that's only in your back. Okay.
Yes, non-specific mechanical back pain.
Mechanical back pain in your back. We're not talking about something that is radiating down a leg, radiating down an arm, causing numbness or tingling at a point of remove from the spine itself. We are talking about pain localized to the back. And if you've got what would be considered neurological symptoms, that's not what we're talking about. And I would imagine that, instead of me guessing at it, and I've got a number in my mind. What do you think is the percentage of people who present with strictly low back pain as opposed to pain associated with radiculopathy?
So I've seen 2 patients that have come in to me with a referral for back pain, and as soon as they came in, I was able to pick up on the fact that this was a screaming radiculopathy, and it was outside of the scope of physical therapy for treatment. So I've had 2 immediate referrals to surgery based off of the patient's presentation. But then everybody else, and I mean, I treat hundreds, if not thousands of these in any given year. Even if they do have some radiating pain, for the most part, I'm able to treat them without any escalation to surgery. Because radiating pain is a little bit funny because we do refer pain to different parts of the body. Even if it's if it's mechanical back pain, people can still have radiating symptoms.
Sure. Sciatica is commonly associated with something like that.
Exactly. And sciatica, it's kind of a garbage term, but, it just means that there's radiating pain down the sciatic nerve distribution. And so that's where a good, competent physical exam can identify whether or not this is a true nerve root impingement that's causing progressive neurological impairment, or if it's not that and it's just central back pain, then we can work on that. There's something else too that some people, it's very, very, very uncommon, but people can come in with centralized low back pain that have something like a tumor in their spine or something like that. And that's again where a good competent physical exam and a good thorough history of a patient's symptoms will help weed that out. But those are the kind of the red flags that you're looking for stuff like that are very, very stark. And what tends to happen is people maybe the most useless subjective report that I can get from a patient is that they have numbness and tingling, because we don't really have a good understanding of what that actually means. And people, I would say probably a quarter to maybe a half of the patients that I have come in here have some degree of numbness and tingling. Whenever you ask them the question, do you have any numbness and tingling in your legs, in your feet, in your hands? People always say yes, but that could be from a lot of different things. I see it very common that people have numbness in their feet whenever they run, and it's probably because they tie their shoelaces too tight. Right. It doesn't mean that they're, and that
may or may not be associated with the report of the low back pain. So the number in my head was 95%, but I gather that you're telling me it's much lower than that.
I would say probably 95 to probably 98% of people who come in that have back pain, they just have back pain.
Right. So
It's a
the
very
vast
small percentage.
right. So the vast majority of people that are asking to be treated for low back pain are certainly candidates for a much more aggressive approach to back pain, which would be squats and deadlifts. The problem, of course, is that people with low back pain are going to have to be very carefully taught how to do this. There's going to have to be careful explanation about why it's okay to do this, the right way to do it, and be walked through it a step at a time so as to be made comfortable with the idea that they can, in fact, use their back. The problem, of course, is that there are virtually no physical therapists and absolutely no physical therapy schools at this point who are generating DPTs that are competent to teach the squat and the deadlift to people in this demographic. And that's unfortunate because the two most effective therapies we have, the squat and the deadlift, are the least two that are likely to be accessible to a typical patient through a physical therapy clinic. Damn it. You know?
Yeah, if you look at, they try to like set up like clinical prediction rules for low back pain. If somebody meets this certain classification that they've had back pain for less than 16 days or younger, then you do a manipulation and send them on their way. If they come in, if they're hypermobile, they're female, they're a little bit younger, like you do lumbar stabilization with them and stuff like that. But for the most part, I mean, most everybody that comes into my clinic is either going to be appropriate for manipulation or not. If they're not appropriate for manipulation, then maybe I can do some manual therapy to just kind of do some joint mobilizations. But unless somebody has a screaming radiculopathy, and I go through at length trying to explain this to patients, that the way that you're going to actually not only make the episode of back pain shorter, truncate it a little bit, but also help make these episodes come like at longer and longer intervals between each other, is that you have to load the spine. But I'm going to show you a precise way to load the spine so that it's safe, that you conduct the movement, and that you have rather than have somebody come in and do 3 sets of 20 prone planks for whatever, or do supine bridges or something, what we normally call as lumbar stabilization exercises. I show them, we're going to have you squat. I'm going to put a weight on your back. I'm going to have you do all that stuff that we do with lumbar stabilization. You're actually going to do that whenever you do the squat. So you get the benefit of not only loading the spine with a progressively loaded resistance that you can actually see progress on the bar from workout to workout, which is something that I can't give you whenever I have you just do mat-based lumbar stabilization exercises. Mm-hmm. I know that this is standard of care, that you're supposed to lay on your back and raise your butt up off the ground and do stuff like that. But I'm going to give you something a little bit better, because you're going to do all of that, but you're going to do that with a progressively loaded system, and you're going to be able to see every time that you're getting stronger. And we do the same thing with the deadlift. And sometimes, like I said, I have to tell people, I'm going to teach you how to lift something off the ground the right way. Teach them how to lift, because everybody's been told that you lift with your legs, and which
meaningless nonsense.
It's meaningless nonsense, and it's one of those things that, like, at face value, it seems like it makes sense. Use your legs instead of your back. But what you don't know is that whenever you kneel down to the ground to pick something up, you put yourself in an extreme amount of lumbar flexion. You get this big posterior pelvic tilt. Your lumbar paraspinals are very stretched at the bottom of that. And as you start to come up with the resistance, what happens is now your low back starts to get in a little bit better mechanical position to actually contract. So it's coming under tension dynamically. And then by the time that they stand all the way up with it and they have to carry something, what did they do? They lean back with it to make it a little bit easier for them to carry. So they're going from lumbar flexion all the way to lumbar extension dynamically with a load. And then I can show that to them in a mirror, have them see that actually happen, and then show them how to lift something off the ground correctly, and show that they're able to maintain that neutral lumbar arch, and that they're in a little bit of extension, which I explained to them is safe, and have them do that. And more often than probably other people, the patient looks at it and says, yeah, that actually makes sense. And then I say, okay, now we have to get you in the gym and we have to make you deadlifts. And as long as they're willing to do that, I can't think of anybody that I've gotten on that program that has come back that has not improved significantly.
Well, I was going to ask what kind of success rate do you have with a squat and deadlift approach to treating back pain? You've got you've got a more compliant demographic that you're dealing with than the general public, right? Or am I'm misinterpreting the military situation there?
I think that you may be misinterpreting the military situation. One of the biggest, I would say that from my experience working with the military, you get about 50% of the people that come in, and that's really what they want to do is they want to get back to training, they want to get back to their job, they want to get back to their career progression, and they're tired of some kind of injury hindering what they want to do. You have about 50% of the patients that I have come in that really have no want to continue with military service, and they use whatever kind of injury that they have to help start the process of getting them out. And the military, a lot like workers' compensation, I would say about half of the patients that I have come in are kind of along the lines of like a workman's compensation claim patient, because there's such a large amount of secondary gain to having pain in the military. Because if you're shown to be disabled from this type of pain, then you can receive, compensation for the rest of your life. Plus, it can also get you out of the military.
Yeah, I hadn't even thought about that. That's unfortunate also, isn't it?
What I do like about my population, though, is that I do have, unlike workman's compensation, which is that's a totally different animal, and it's something that I have very little experience with. But with my population is, as long as they get to me at the right time and it hasn't gone too far down that kind of chronic pain level, that a lot of times I'm able to kind of turn the tide with these people. But I would say that for people that are willing, people that are able to squat and deadlift, I'm probably batting over 90%. I'm probably batting 900 or so with these people. As long as they'll squat and deadlift, they get better. And that's standard prescription. If they're not willing to do that, I'm probably like everybody else. And it's probably maybe 30% get better, maybe 25% can maintain their symptoms, and then maybe 30 to 50% end up at somebody else's office, like a pain management physician or something like that.
Gets worse. Right. Well, I'm glad that your experience comports with mine. We've had very good luck with teaching people how to pull and squat in here, and very good luck with treating common complaints of back pain that develop amongst our members, because they're upright humans, not because they're lifting weights, but because everybody gets back pain. I know you've read the boards, and it's interesting that we have so many accounts on the board of people with chronic back pain just biting it off and starting to deadlift and squat, and almost the universal response is that they get back on after 3 or 4 weeks and say, my back's been hurting for 5 years. I started the program and it's gone. It's absolutely gone. There are thousands of those posts over the past 11 years that we've been operating this board. There are thousands of posts that reinforce that experience that you and I have had as essentially clinicians with loading people's backs with the squat and the deadlift. And I think it's interesting that our rate of success with these people is so much higher than that of conventional medicine, conventional physical therapy, yet nobody is using our approach but us. And is there any way to change this paradigm, you think? Or is cover your ass so thoroughly built into this medicine model that that's just the way it's going to be?
I think that there's a big shortcoming with the whole evidence-based practice model. It makes sense, and we should use the best available evidence for some of our treatments. But there's sometimes that we do need to understand the simple fact that sometimes the wrong research question gets asked. Sometimes there's a poor design to help try to answer that research question, and clinical expertise, clinical intuition, stuff like that has kind of gotten trumped by what does the evidence say. And you look at some of the evidence, and I mean, there's some studies out there where they try to use deadlifting to treat low back pain, but you look at the studies and there's a very poor description of what the deadlift actually means. So yeah, I mean, if you have people do kind of like a squat pull type deadlift, which is what, kind of your general issue deadlift that you see in the gym, of course it's not going to help.
Well, or people perceive that a kettlebell deadlift is better because you can keep your back at a more vertical angle, and of course they misunderstand all of the very nature of pulling mechanics in making that assumption. And but they think they already know, so they're going to try, or they'll try trap bar deadlifts in order to try to get as vertical as possible, thus missing the point. And I don't know,
I think you have to kind of
frustrating that there's this level of misinformation.
I think you have to kind of look at like what physical therapy and what medicine is doing. You have to see who's joining the boards, who's becoming starting strength coaches, who's actually putting some mechanical analysis into some of the stuff that we do. You got people like Doctors Feigenbaum, you got Dr. Brockie, Dr. Sullivan, you got Dr. Patrizio, you got Nick, who's in physical therapy school now. You got all these guys that are kind of seating themselves in different allied health professions or medicine as a profession.
In addition to several people that are posting on the board with some frequency that are practicing physicians in various disciplines that are wholeheartedly endorsing our approach to these things.
And I think you'll see it as kind of more of like an insurgency. I mean, we're probably never going to change the paradigm throughout the entire system. I think that would be a ridiculous goal. But I think that, the more people that you get kind of out there and at least using some of these principles whenever they're prescribing stuff to, I mean, if I could get a family practice physician to have people come in for back pain and start that conversation with them very early. Hey, you need to squat, you need to deadlift, because that's the only thing that you're going to be able to do to strengthen your back. That lumbar stabilization exercises and Roman chair, like hyperextensions and stuff like that, don't really train your back the way that you think that they're doing it. That we need to load your spine. If we could start doing that, I think you're going to start having some change. But then again, we're probably still always going to be the minority, because in large part, a lot of physicians, a lot of physical therapists, a lot of other health professionals are always going to err on the side of being conservative. And then a lot of patients are always going to err on the side of passive treatment.
Right.
That I have something wrong with me. You as the doctor, I want you to do something to make me feel better. And sometimes it's, and if you look at, if 60% of the population is overweight or obese, then you look and you say, well, we do have a physical activity problem. And if what you have going on with you is going to be cured with physical activity, we can't even convince enough people that physical activity is necessary just for life, let alone with back pain. And so you start having some of these things: obesity, diabetes, heart disease, joint pain. You have all these things start to compound on each other. And then, we're still looking at, a fraction of the patient population that comes in that will ever want to do this. But
I think that what we have here, I think that getting everybody deadlifting, squatting is a wonderful goal. I just think I think you're wrong about that. I think it's a wonderful goal. I do, however, agree that it's a ridiculous expectation in today's.
Yeah, that's probably a better way to.
Today's people are just. I understand that, and I understand the level of frustration that even enlightened doctors. One guy posts on the board that was recently here at one of our seminars. talks about this. He said that it's all he can do to get people to not put sugar in their coffee, much less get up off their ass and squat and deadlift. They're just not going to do it. People have not been raised to do things that are uncomfortable, and as a result, it's probably a ridiculous expectation. But what Will and I are telling you guys that are watching this is that we have the tools if you will use them. We understand that you're reluctant to do it, primarily because you're lazy. But what we're telling you is don't be afraid to try. Okay? Will, thanks for being with us. And
Thanks for having me.
We appreciate your joining us on the podcast, and we'd like to thank you for watching the podcast with us today. We'll see you next time. Thanks.